We're going to go to our next live case from Singapore, and if you could sort of help us chair this session. It's a case of a Medtronic core valve implantation, if I understand correctly.
Yeah, good morning, everybody at Singapore. I'm Dr. Aman Salman here. Can we know who is the operator today, and you could introduce your team to us, please?
Aman, welcome to the National Heart Center's live transmission program. My name is Goh Tian Hai. I'm the medical director of the National Heart Center, and we have a team here that's doing the TAVI program in our heart center. I have here with me Dr. Paul Cham, who is my senior consultant and the lead operator for the TAVI program. And also have Dr. Victor Chow, my senior consultant surgeon, who is also the co-lead for the TAVI program here. Yep. So we also have our echocardiologist, Dr. Yi Sui Hui, who is have an interest in this interventional program, and Dr. Sito, our anesthetist there at the back. Yeah.
Yeah. Morning, Prof. Sorry, I didn't know you were on the other side. I thought it's Paul who will be doing the case.
Also in the program and very helpful to us.
Okay.
So, good morning. May I know who's on the panel right in India? And
I see Sister Kwok also there. Okay. So morning to Sister Kwok and all your team.
Yes, and Sister Kwok and all my team nurses are there. Yeah.
So we are waiting for you to start, and you can introduce the case to us and go ahead with your case. We don't want to keep you waiting.
Okay, sure. Yeah. Okay, probably do it.
Okay, no. So Paul will do the.
So can I have the first slide, please? So today we're going to show a case of a core valve TAVI, and over here in Singapore we actually use both valves, and you can see just a couple of slides on our own experience. 53 cases of both Edwards and core valve, and you can see a mix of mostly transfemoral but also transapical, and a few direct aortic with the core valve device, and that's our patient profile. Next slide, please. And you can see the 30-day mortality early in the experience, about 9 overall. The transfemoral mortality is 5.8% at 30 days. Next slide. And most patients do quite well. Most of them end up with mild paravalvular leak. That's a big concern now. We also have done one case of aortic valve-in-valve, previous gentleman, end-stage renal failure with the degenerated aortic bioprosthesis. And next. And that was with a core valve device. Not sure you can see clearly, but you can see the core valve inside the previous Carpentier-Edwards device. Next one. And also with the Edwards device, we've done a mitral valve-in-valve, which is a very nice procedure for some of these patients. And next one, please. You can see here the degenerated mitral valve with severe MR, and you can see the balloon being inflated inside the previous mitral annulus, and the 3D reconstruction showing the sewing ring of the previous bioprosthesis and the Edwards sapien valve inside. Okay, so anyway, that's a short introduction on our experience. Next slide, please. Next slide, please. Can we show the slide, please? So today's patient is a 72-year-old lady, background of hypertension, and the main problem that contraindicates surgery is pulmonary fibrosis. She's on long-term prednisolone, about 2 milligrams daily. And the lung function, the very recent one, you can see a FEV1 of 1.25 liters. So it's a restrictive lung disease. FVC is 1.39. And the CT scan shows you the honeycombing of the lungs that is very prominent. This is basically throughout the entire lungs. Next slide, please. And she presented basically with increasing shortness of breath, NYHA class 2 to 3, more 3 now. And I think the main difference was that the echo showed the progression of AS from moderate to severe its severity right now. So she was referred to us for consideration of TAVI. Next slide. And I think basically we can discuss here, how in a patient like that, this is the steps that we do here. We confirm how severe the AS is, and then we have a heart team that assess the risk for this patient for normal open heart surgery. And then we assess if the TAVI procedure is feasible, and look for other contraindications for TAVI. And then, of course, then we select the size or the appropriate prosthesis now that we have 2 valves, and of course the best approach for this patient. So does anybody in the panel have any comments about this case?
Yeah. This is Dr. Ashok Seth speaking. Can you hear me?
Hey, Ashok.
Hi, how are you?
Yes, yes.
Now,
okay, good.
I just, one thing which was interesting for me was that the mean age of your group has been 72, and this patient is also 72 years old. Now that's interesting, because that's much younger mean age than one I would have experienced.
Yes. So
yes.
So I think that is our experience. The patient population in our center seems to be a bit younger. A lot of the very, very elderly patients actually do not want anything done. So even though they're high risk, we speak to them in the family, and they are not keen to anything done. And most of these patients who are at this age, I think our mean is about 74, 75 maybe right now. They are high risk for various reasons: porcelain aorta, high Euro scores, high STS scores, previous open heart surgeries with patent grafts, and these are some of the reasons we do them. But we are looking at patients who are generally younger than in the West, and I think that's finding that perhaps is being seen across Asia. I'm not sure what is the experience elsewhere, but it seems like at least in our population, the cultural preference is quite strong for very elderly patients not to have anything done.
What is the experience, Ashok?
No, what you said was right. It's not because they're getting aortic stenosis at a younger age. It's because it's the younger population who's willing to actually have a TAVI procedure rather than the elderly age group. And then there's one more thing, that we have a higher proportion of patients who've had a previous heart surgery than I'm sure we have in the West, because these are the patients who say, we're not going to have surgery again, let's have some other procedure. Do you agree with that?
Yes, we have actually quite a number of patients who have bypass and also had, like, say, CA lung or porcelain aortas that contraindicate low-risk surgery. And that's why our patient population group is relatively younger.
Hi, it's Sushil Kadali from New York, Columbia University. Our experience has always only been with the Edwards Sapien valve. But one of the things in this case that you presented that we struggle with is patients with severe lung disease. How do you differentiate how much benefit they'll get from fixing their valve? And we've done a lot of these cases. Some of the extreme cases, we've done balloon valvuloplasties to see if we think their AS is going to, fixing their AS is going to impact their symptoms. What do you do in these type of cases? How do you make the judgment? I appreciate what you're saying about it's truly a team consensus, but do you have any thoughts on scenarios like that?
Yeah, hi, Sushil. I think we met last year in the London Valves, Paul here.
Yes.
So this patient actually, I was in close consultation with the respiratory physician who felt that the recent deterioration was really due to the severe AS and not the pulmonary function, which has been relatively stable. In fact, her blood gases, the PaO2 was something like 70 on room air, and that was pretty decent for kind of a lung. And the treating physician, which has been seeing her for the last 5-10 years, really felt that she would benefit from this TAVI procedure.
Oh, great.
So I agree, sometimes it's difficult to know how much they will improve, and we haven't had many of this. We had one other patient with severe COPD, but he did very well, and so far that's our experience. So not a lot of these pulmonary fibrosis patients that we have.
Great. If you want to go ahead and proceed and show us some of the screening
so
studies you've done.
can we show the slides again? So we go through some of the patient data. So next slide, please. So this is basically what the various valves and the annular size. I wouldn't want to spend too much time, but basically 2 valves, and you can see here the annulus. The smallest annulus for the core valve is 20 right now, but of course the 23 mm valve has just got CE mark approval, so then they will go down to about 18 annulus, which is the Edwards lower limit. Next slide, please. And you can see here on echo, there was the findings, mean pressure gradient of 70. The annulus was about 21 mm on transthoracic. Next slide, please. And on the cardiac cath, we found the mean pressure gradient about the same 81, and this patient's logistic Euro score by calculation is 7.7 and STS of 7.9. So next slide, please. On the CT scan, you can see that the annulus looks a bit bigger, about 22, and we use both the perimeter and the area method. And I got to thank Dr. Yu, my echocardiographer. She's really published a lot on this area and done very well on the CT and imaging parts of TAVI. And this is the 3-Mensio software that we're using. Next slide, please. And I'm not sure you can see this very well, but it looks a bit dark here, but the aortogram on angio. Next slide. And I believe, next one. And this is the moving image that you can see here, which we will show you today. So basically, we try to get all 3 cups aligned so that during deployment, we get a good view of where to position the valve. Next one. And of course, very important in these patients are the aortoiliac access, since we're coming to a transfemoral approach. So over here, we're looking at the coronary height. So this patient is a little bit challenging because if you look at the on the CT, the coronary height is a bit low. The left ostium is about 8-9 mm, which is a bit lower than we like. The right is about 10-11. So it is a bit low, but we looked at it and we thought she'd probably get away with it. And that's another reason we chose core valve for this lady. If you know, the core valve design is designed to be constrained to avoid obstructing the coronaries, and perhaps this is one advantage of this valve for this particular patient. Next slide, please. And this is the angiogram of the aortoiliacs. Just looks patent. The right is a little bit more tortuous, and that's why we've chosen the left approach for today. Next. Next slide, please. And this is the CT 3D reconstruction of the aortoiliacs. You can see here, we can look at it to look at how much tortuosity there is. A lot of work for one patient, and we have really a good team here to do all this pre-procedure imaging. Next one, please. And on the CT scan, you can see the measurement large enough for the 6 mm that we require. The right slightly bigger than the left. Next one. Okay, and next. And therefore, I think we've discussed some of the issues. Which valve, I think our team thought the core valve might be better for this particular patient. And of course, the transfemoral approach seems to be feasible here. Any comments from the panel?
I think, oh, sorry, go ahead.
Yeah, I have a comment. It's interesting that you're a center which has experience with both the Sapien Edwards as well as the core valve. You have more experience with Sapien Edwards in your numbers than you have in core. How do you decide? I mean, this is fine. You made some decision based on the height of on the distance of the coronary ostia from the annulus. But what in general is just what you feel like? Is it just what you think you want to do on that particular day?
Okay, so it depends on who buys more lunch. Oh, I'm kidding. So anyway, okay, so seriously, we have done more Edwards because we started with Edwards earlier. We started in February 2009 with Edwards, and core valve only came to us in 2011, January. So that's about a year and a half off from Edwards. But in any case, I think for most part, about 80-90% of patients will be suitable for either valve. Now, the consideration comes into the annular size. Although Edwards, the device is an E-sheath, 16 French, very small. But for the bigger valve, you need the 18 French E-sheath, which then expands to about 19 French sheath in diameter. So with respect to annular size, at least, the core valve has advantage because whatever, regardless of the annulus measurement, the sheath remains at 18. So that is one factor that we consider. The other will be the root, the whole root anatomy. How big is the annulus? What is the sinus measurement? What is the STJ? What is the ascending aorta? And then all these will be taken into consideration, and we choose the best choice for the patient. All being equal, I think we will just probably, if everything is equal, then I think we just alternate companies just to be fair. But I think most patients tend to select themselves better for one valve than the other, I must say, from our own experience.
I'd like to just make a few comments. I want the audience to sort of appreciate the amount of screening that you did. And I think that's a key part of the success of any program. The first part you went over very nicely was the description of the aortic valve anatomy and the surrounding structures. Annular size, just a couple of questions just real quick. Do you go by the mean diameter? What are you basing your annulus size? If it's an elliptical annulus, are you going by the mean diameter, derived by area, derived by perimeter? Are you going by mean area? How are you deciding which size valve here? And how much do you oversize with the Medtronic core valve compared to your annular dimensions?
Yeah, so the dilemma comes when the measurements are different. I think at the end, we probably go with the CT, and I think most people will use either area or perimeter. I think the perimeter is very good because that is where exactly the valve is going to sit. And I think for the core valve, the recommendation is to oversize about 15 to 20% by perimeter. And if there's any doubt, you can always refer to the company. They have a chart to tell you what the perimeter is, and then we can But saying that, you can always derive the diameter from that measurement, and most times it's pretty accurate. Whatever it can be a little bit elliptical, but the end result, you make the annulus mostly circular, I think, for most patients.
Interesting. So you oversize by about 15%. It's a little bit different. I think it's an important point, the self-expanding valves versus the balloon expandable. And I think, now that we have a better understanding of the 3D anatomy, at least from our perspective, especially with the balloon expandable Edwards sapien valve, we don't tend to oversize as dramatically. If we have very confidently a 21.5, 22 annulus, and it's very symmetrical, we might go with the 23 valve depending on the other anatomy. The other point you had raised was the risk of the coronary occlusion. And I think those are numbers that are concerning. And I think an important point, as you mentioned, is it's just not the height of the coronaries. It's not the prosthesis that occludes the coronaries. It's the native leaflet. So if there's adequate space in those sinuses for the native leaflets, even if the coronaries are low, based on the CT, your risk of occlusion is low. What are your thoughts, and how are you assessing the risk of coronaries in a scenario like this? Besides just the height, are you considering looking at them during a balloon valvuloplasty? Someone low like this, where their coronaries are low, would you consider putting a wire in the coronaries to help protect them in case you do occlude them?
Yes, so this we've also discussed, and I agree with you. Not only is the height important, but also the width of the sinus and how much space there is. For this particular patient, we're a bit more reassured because the left cuff is not very heavily calcified. Hopefully, it's not so bulky that it will obstruct the coronaries. That's number one. Number two, the point about putting the wire in, we've discussed it. I think that technique is good for the Edwards sapien valve because the wire will not be sort of jailed by the device. But for core valve, the wire will obviously be jailed against the ascending aortic wall for this particular patient, and it might not be so useful. So for this patient, what we're going to do during valvuloplasty is we're going to take an injection and see whether the coronaries are patent. And if that's the case, we'll proceed to implant the valve. And as you know, core valve is functional at 2/3. So at 2/3, we're going to wait, do a root injection, and make sure the coronaries are patent before we release the valve. So that is the approach for this case.
One very important point and important question is, and there is a discrepancy between CT measurements and echocardiographic measurements. So what do you actually take into account? Which one do you actually take?
I've discussed with Piazza on this. He's published many papers, and I think in the end we agree that the CT has to be the final one because you can never be bigger than the CT. Your echo will always be smaller, right? Because whatever you do, you can never get a diameter that's bigger than that. And the echo will always be smaller if you're not at the true sort of the biggest diameter of that plane that you're cutting through.
And because
with the CT, you get this 3-dimension.
Because these are oval orifices, are you relying more and more on the perimeter, making CT a mandatory for these assessments?
Yeah, so it is always done if the patient's renal function is okay for the CT scan. But in some patients whose renal function is bad, then we cannot have the CT, and that's something we've got to compromise. But I think by and far, if it's possible, the CT is really useful for this procedure.
I don't want to hold you up as well. There's about 40 minutes left in the live case, so you tell us when you need to move on, and you've shown us the vascular access and everything else.
So if you can show here, we'll show you what we've done so far. If you can look at the sheets, we have a 6 French in the right common femoral artery, and that's the pigtail inside here. There is a venous access just as a backup, and this is the 18 French sheath that we have already put. And you can see here, if you can focus on the sutures, the 4 ProStar sutures that I put in. So this is the percutaneous closure device. We pre-close the groin. And can we now move to the angio, please? You can play the angio.
Is the patient under general anesthesia here, or?
Yeah, so we have done almost all our cases under general anesthesia, and we've discussed about this particular patient because of the lung disease, but our anesthesiologist feels really more comfortable with general anesthesia, and the FEV1 of 1.2, 1.3 is not an issue with her. So if you can look at the screen now, this is the root shot we have done today. You can see here is this view is 0 and AP caudal 20. So it looks like a good view with the 3 cups nearly aligned.
You can appreciate the tortuosity in the
just
aorta
like
there.
to.
Yes.
Is that a problem
That's
for the device in terms of tracking in the abdominal and thoracic aorta?
I don't think so. So in fact, Sushil, right? I think this is a better patient for the core valve than the Edwards because we don't have to prep the Edwards device in the body. So the valve is just like a stand. You just bring it around and then deploy it. So can we go back a couple of slides? Let me show the access. I think is very important for this back, please.
Yeah, and the aorta is more horizontal, and I think that's another point to
Yes. Yeah. Yes.
keep in mind.
So back one. So this is so for the access. I think it's very important to puncture at the common femoral or just above and below the inferior epigastric artery. And this is how I did it on the road map. You can see my needle and my hand there. Of course, gets a bit of X-ray. Next, and we can play that. This next one. Next. No, next, forward, you're going back. Forward. Okay, and play that if you can. So this is unfortunately, we saved this on the road map, but you can see the ProStar sutures. So this is what you must see, all 4 needles and sutures coming up in the same plane, and none of them is stuck in the artery. Okay, so, so that's where we are, and let's go back to the angio, please. So why don't we go live now? And you can see our pigtail is in the LV apex. It's the ventricle is quite small and it doesn't look like a nice position, but we'll try and see what we can get with the wire. So, does Pedro have any questions at this point?
I think we should move on.
Yeah.
Can you show us the TE appearance of the annulus and the coronary distance? Or have you measured those by TE as well, or just by the CT?
Give us a syringe.
CV, you want to show?
Sorry, can you?
Yeah, they want us to look at the TE.
Can you show the? No, but you're not showing. Okay.
So go to REO 15, please.
So this.
The appearance there. I'm sorry. Go ahead.
Center table down a bit more to the apex. So it is a loop, not the way we want it, the nice loop, but it's indeed a loop, and I think we'll leave it. We're happy with that.
Was there any concern that it was a bicuspid valve there? Just that one short axis image, it looked a little bit suspicious.
Oh no, the CT clearly shows three leaflets.
Okay. Have you done?
So now we're going to do the valvuloplasty. Yeah, I reported one case in Jack, the image, a bicuspid valve with Edwards, and we managed to achieve a very nice circular expansion. So we've done a couple of bicuspid valves, yes. What about you, Sushil?
Very limited experience. I mean, the true
10.
bicuspids, usually the annulus is too big for our current devices. The one issue I think here in Asia as well, there's the incidence of rheumatic disease is so much higher that you're going to be seeing this a lot more than we do in the U.S. Is the percentage of your patients, are you doing some rheumatics as well?
Yeah, we've done about 4 rheumatics. So far, we haven't had any problems with the valve on the rheumatic valves, surprisingly. But I guess the rheumatic valves are all also degenerated and calcified. Go to implant view with 20, right? Yeah. So right now we're going up with the balloon. It's a 20 mm by 4.
So tell me, Ko, are you in favor of underdilatation or optimal dilatation of the valve?
Right. For this case, we're choosing the...
So would you just stop at 20
choosing
if
a
this was
20
a 23 valve, or would you want to go up to 23 millimeter balloon for a 23 valve?
Okay, fix. Caught with this thing. Hang on one sec. My pigtail is getting caught in the balloon.
So I'll answer that response for Ashok.
Okay. All right. Okay.
I think systematically we
pacer
prefer underdilatation as opposed to true size dilatation. We don't really see any particular benefit for true size dilatation. except I think
So
you
get
may
ready,
cause
Jack.
more disruption of the native valve, you may cause more AR, you may in fact cause more in the way of ischemic embolic complications. So we would prefer to do a very controlled, single underdilatation
Is that ready?
with pacing and then go straight
Is
to
that ready?
implantation. And I think that's been the trend both with CoreValve and with Edwards.
Is that on?
Marty, do you change your practice based on, say, severe
Check the dye.
calcification, chunks of calcium, so on and so forth?
Down.
Do you worry
Down,
that
down.
your valve, especially for core
that
valve,
off?
that it may not expand well enough symmetrically and have more aortic regurgitation if it's underdilated?
Can't see anything. Because the
I mean, of course, that's a possibility, but the observation is that for the most part, where CoreValve sits in the annulus, in the annular zone, it generally is somewhat oval, but since the valve is actually supraannular, that it will be circular where the valve is, and even by being more aggressive with pre-dilatation, I don't think it'll affect acute valve performance.
Well, I saw
So
the
we've done the
you injected a contrast. Was that to
Yes.
look at the coronaries? Was that your concern?
yeah, correct. But the balloon unfortunately is obstructing everything. And but you can see, play back the image, please. The valve, please.
It didn't look like there was much flow in the left with the balloon inflated.
Yeah, but it could be that the balloon was just obstructing everything. I'm not sure the leaflet was the problem.
And
Play to the,
we do that often too. It's a difficult thing because with the balloon inflated, and if you do it during rapid pacing, you're not going to get as much flow or contrast. You know, we put the pigtail above the balloon.
One leg down, please.
If we see flow, we feel very reassured. We also look on TE echo as well to see, you know, what the flow in the left main looks like with the balloon inflated, and to see if it sort of fills that space. Those are other clues. There's no absolute certainty you can use.
Save that. Right, I agree. And sometimes it's really difficult to know exactly what is the best. But here we're coming up with the CoreValve device.
Okay, so this way. Let me.
Show up a bit. Okay. Down a bit, please.
So what's the size of this valve?
This is a 26 mm.
Okay.
Okay, so we're right at the aortic valve, and let's get everything ready.
Sorry, can you turn 60 degrees?
Okay.
Now you selected this view because this is you felt there's a coplanar view where all the leaflets cusp lined up.
Correct. Center, yeah, center. Correct. So when we shot the aortogram, the 020 caudal is the best view that we could find. Okay, going in. So right now we're going.
We do that as well with the CT, and I think it's a good way to find it. Yeah.
Okay. So maybe give me a bit more caudal, 25.
Except that the marker band on the withdrawal sheath seems
30 caudal.
to certainly be a greater emphasis on the marker band, and we tend to actually change
30?
the views
Right. Okay,
if the marker band is not the
more.
same as the three cusps in a single plane.
So right now what I'm doing is I'm closing the ring. If you notice, when I first came in, the ring was open, and now I've closed it to make it a single line, and we had to go to a steeper caudal view for that. Okay, Siwi, I need to put up a bit.
Yep.
So 10-10. Higher approach, please. So right now we're going to deploy it. You can see the marker rings there. The first ring is where the sheath is, and then the 0 is. So if you, the most bold one is not counted. The first marker is a 0. Okay, and we are sort of 4 mm below the annulus right now.
Yeah.
Already up.
I think that's an important point. So what is your goal? How far below the annulus do you want this, the bottom of the frame to sit?
So right now we're deploying it. We're starting about 4 millimeters below the annulus. I think that's been found to reduce the need for pacemaker.
Right.
So, and if you know the Edwards is 14 mm in height, so it'll be 7, more or less 7 below and above, and this we're aiming 4 to 6 right now.
Just one question before you start deploying, so that I don't want to interrupt when you deploy. I prefer that the marker band on the withdrawal sheath is absolutely a straight line, because that's what you're looking at, and the 4 millimeters depends upon that rather than your 3 cusps in a line. And those two are sometimes very different. This is what I really concentrate on. Now, what is your view on this? Are you concentrating on your marker band being absolutely perpendicular, and therefore you seeing because that's what that's where you're going to come out from?
Yeah. So we can go a bit more caudal, or we can go L. Try it with L5. No, I agree. We need to get this in a line. It's not too bad right now. That might be better. Okay. How is that? I think that looks better.
Yes, that looks better.
Yeah. Okay. So let's take a sitting. Check. Looks good there.
You tell me the number.
So the hemodynamics are completely stable at this point too, which is I think one of the
Oh,
things
it's
that are
stable.
missing.
It's very good.
636. 636.
Okay, start here. Okay, start. Okay. So we're going to start releasing.
Okay, yeah. Releasing.
Bring the first ring.
Releasing.
Looking at the pigtail, you look deep. Just have another look.
Releasing.
You look deeper than I think you should be.
Releasing.
We want the pigtail right against the non-coronary cuffs
Correct.
as low as possible.
And
because that will serve as the marker during the,
Yes.
the deployment.
And compared to that, you look deep. That's what I'm trying to say.
Right. Go a bit more.
A bit more. It looks a bit deep now.
No, you're not at the zero. Right? Yeah. Coming. Bit more.
Okay.
Okay, stop.
Yeah.
Okay, sitting. Inject. Yeah,
Too deep.
I think, okay, looks okay. Looks good here. What do you think? The first marker is just at the lower limit of the annulus.
Yeah.
I think looks good here.
Are you looking at echo at all or not at all at this point?
Not
I'm
really.
out of view.
Yeah.
I'm out of view.
Yeah.
Releasing?
Yeah, releasing.
Okay,
Second.
releasing.
So we're going to the second ring right now. As you can see, it's moving. Second ring.
Releasing.
Okay, smooth down a bit.
Releasing.
Okay, stop there.
Watch the medial edge of that stent as it comes out.
Huh? Gloria, right? Gloria? It's okay.
Now this looks good.
Looks pretty okay to us right here. We're at the first ring.
Yeah.
So let's go. Go second ring.
Releasing.
Go.
Releasing. And go slowly.
Yeah.
The pressure is still okay. Releasing.
You need to capture
A bit higher.
put it like that. You capture for me.
Yeah. Moving back. Yeah. Hold back a bit.
Because now.
Yeah, I think that release first.
Yeah.
Release.
Fine.
Releasing.
Okay, stop. One more cine, please.
I think just go all right.
It's okay. Come up.
No, I think
It's okay, right? Third ring.
okay. Releasing, huh?
So important to just take your time.
Releasing.
Yeah.
Releasing. 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 Releasing.
Bit more.
Releasing.
This is so different to Sapien Edwards.
There's no rapid pacing.
Injection.
No echo.
It's good there.
Bit lower.
Gloria looks good.
I think you're deep. Are you still in a position to pull it?
Yeah.
I think it looks
Yeah.
looks okay. Oh, it
Okay,
open
go.
out a bit.
Yeah.
Okay, release.
Go. Yeah, release.
Huh?
Yeah. Go 2 thirds now.
Release. Releasing now.
I mean, as you release, there's a tendency for the device to dive inward to the ventricle, so you have to keep some level of constant pressure. And I think that's where the experience and the operator technique plays an important role here. So there is some tension on the system,
Release a bit.
Okay.
and sometimes you do have to recalibrate the location by pulling the entire system back during release.
A bit deep.
Low. Gonna pull it back.
Okay, the vibration.
So, Ashok, this looks like it's close to 10 millimeters below the
Correct.
non-coronary cusp.
Yes. Yes, it does.
Which is a little bit longer than ideally you might want, I think.
Yes. In fact, one's gone on to thinking that even 8 millimeters is too much, and one's gone on to thinking that perhaps it should be somewhere around 4.
Yeah.
But this one is because the lower coronary.
Let that pressure tension first. Pour out everything.
So right now I'm trying to pull back a little bit.
With this device, once the valve makes sort of annular contact, the valve starts functioning. Is that correct? So the patient is...
A bit. Yeah.
You don't see his flow in the left coronary there with that injection. Are you... is the LV on echo and the hemodynamics look okay?
So here always is a delicate time. You always look at the electrocardiogram just to make sure. I'm not certain. When we looked at the literature, it's not entirely clear. Theoretically, I think the core valve may be safer in patients that are at risk for coronary obstruction, but I'm not sure that the literature clearly indicates that. I think the event rate for coronary obstruction is very low. It's about 0.5%.
Take a shot, see the coin.
Okay, so we release the valve.
Right.
Let's take a Sydney.
So how's everything looking?
The pressure is a little bit on the low side. It's about 70 systolic. But the ECG looks fine.
Is there any mitral regurgitation?
Yeah, let's look at echo and see.
We need to
Always, when you have a deep placement, it's possible that it can interfere with mitral valve function. So you always have to look at mitral valve function, coronary flow, paravalvular leak, left ventricular function. You have to look at everything.
We can see that, see?
And that's why we feel
Mitral
that
is a bit mild, that's
transesophageal echo is helpful.
The LV function is okay or not, contractility?
The LV
There's no
looks
leak
the
I can
same,
see.
LV function?
Make sure Kenny's around.
We're asking the echo to look at it. Yeah.
Wait, yeah. Lateral is down. I'm looking at the LV now.
Yeah, it looks down. Is there,
Yes.
would you do an aortogram here to look at flow in the left main? Because
Yep.
that was one of your
Okay,
concerns.
let's ready?
Yeah, that would be my quick
Yeah,
question.
correct.
Is there
We're
flow in the
trying
left
to,
main coronary? Because I believe this was a normally functioning LV to start with.
Yeah, I know. I know.
Yeah,
just
just
keep
a
it up
little
first.
bit
I need to
concerned.
find out what's happening.
You ready now? Suck.
I think we may have a slightly lower threshold for pre-wiring a left coronary.
Okay. Yeah.
We've done about a handful of,
Okay.
of those.
Let's go.
Okay, ready? Yeah? Ready? 10-10, huh? So we're going to do an angiogram now and see.
Down from normal. I think they may have impeded from
Inject.
the left main. Just stand
Right,
by.
no, you just got to reprime it. 15, please. Because the first part, sorry, this initially we suck back, so there's no dye inside.
The contractions look very poor.
I know.
60 for the past 5-10 minutes.
Yeah.
Yeah, okay, inject. Okay. I think we're not winning here. We're cannot go ECMO.
Just look.
You see this contrast stagnating in that aortic.
Yes, ECMO, please. So we're gonna get the ECMO team in right now.
Yeah. You carry on, we'll keep quiet.
Shall we
Yes.
do a CAF?
So let's look out this one.
Okay, can we use
Wait, let me show you. Yeah,
Can we use the centimeter artery?
Victor, let me see. Okay, problem. Okay, walk out.
I mean, the other thing always to worry about is you see
You're
puddling
holding
of
the-
contrast,
Are you holding it?
is to always worry about an
No
annular or
effusion.
aortic rupture when somebody has hypotension immediately after the procedure.
Come, open the sheath, please.
Take a while.
Got a wire?
Yeah.
Open the 70 French
wire.
sheath. This is how big this 18 French.
Yeah. So, come, step by Gauss, please.
Yes, bradycardia. Do you want to start pacing a little bit faster?
Yeah, yep. Can we start pacing, please?
Anyone put in?
Get the sheath, please.
Do a diagnostic CAF left.
Go, get the sheath, please.
So I think you really have to support the patient now. So
Yeah, we're doing
We're
doing an LV.
No, just do the
Diagnostic left.
I think we'll let you, we'll go away from you and let you work in
Okay.
peace right now.
Yeah.
Okay, it sounds like you have some issues,
Right.
so we'll leave you now. if we can,
Right, sorry about that. Yeah.
we can
If
come
it's
back
appropriate later,
later.
we can come back. But I think right now you should,
Okay.
take care of the patient
Left on the branch now.
and
Left
work
on
in
the branch
peace.
now.
Okay?
Thank you.
Good.
So why don't we cut the transmission?
you.
for
Thank
right
you.
now?
Can I have a,
Thank you very much.
that's fine. But can I have the arterial cannula?
Thank you, thank
Okay.
you. Sorry about this.
Yes, I mean, I think one of the issues, and I think this illustrates some of the issues with these procedures, there's a lot of steps and a lot of things that can go wrong. And you see now they're working and they have a coordinated team effort. The important thing is, complications can arise, whether it's left main occlusion, it's hypotension, whether it's, iliac injury leading to bleeding and hypotension. There's a lot of factors that need to be evaluated quickly. One of the concerns in this case was obviously coronary issues, because that was upfront identified, and with the LV function reduced, I think that's one of the immediate suspicions. But you have to be prepared and have a team, and the team has to be prepared to react quickly in this scenario. And what he'll be doing, and it's at this time for a case like this, it's important that they concentrate and not bothered by us in their ear. He'll be getting a catheter, and basically have to wire the left main. And the issue is basically from above with the JL4 catheter or whatever, you can go through the open cells, get a wire across the left main, balloon and stent, and you're essentially stenting the leaflet down. The other thing that we didn't discuss beforehand with them is you need to be prepared for these complications. What he'll probably be doing immediately is if there's issues of hypotension and support, you can go on ECMO or peripheral bypass. So you have a cardiopulmonary bypass machine in the room, you have that 18 French sheath, you quickly can go on bypass through an 18 or 17 cannula in the arterial system on the side of the large sheath, put a venous cannula from the venous axis where you have a pacemaker, you go on support and support the patient while you restore flow to the coronary, if that indeed is the case. But the ability to recover from these type of scenarios is dependent on scenarios like this where you have a coordinated effort. So you saw quickly before we cut away that each person had a role, and they were sort of talking about going on support, and they were ready to going with the catheters to try and open up the coronaries. I don't know if anyone else here has any other thoughts, Marty?
Yeah, I think in your mind you have to go through the likely differential. This was a somewhat low placement, so you have to worry about interference with the mitral valve and severe MR causing hypotension. You have to worry about, as we mentioned, coronary occlusion, which usually is not so difficult to diagnose. Usually they have profound EKG changes and it becomes a fairly obvious diagnosis. You have to worry about things like chamber perforation. Occasionally you can perforate the LV and you can perforate either the root or the annulus. So those are other things that can cause hypotension. You can have severe paravalvular leak, or you can have malfunction of one of the leaflets. You can have intra or central AR, which can contribute to hypotension. Or occasionally a patient can get so ischemic that they just have the equivalent of what we would call a stone heart, and it takes them time to recover. So the key thing is to make the diagnosis and support them while you're making the diagnosis and then reacting appropriately with a very logical sequence of what could be going wrong. And I'm sure that that's what they're doing right now.
I think that's key, is making the diagnosis, as we said, looking at the LV, looking at bleeding and other options.
Yeah, I think Saibal wants to make a comment.
Yeah, as Marty first nicely put in the differential diagnosis of an acute collapse during TAVR procedure, which actually tells you how important it is to have a skilled team. It's unfortunate to see something you're seeing here. But one thing, when you go ahead and try to diagnose the patient, there are two steps. One is supporting the patient, and the other step is diagnosing the problem. And you can't wait for the other. So one team has to focus on maintaining circulation. So it means if you think you have to do basic life support, cardiac compression, go on pump or ECMO as Sushil pulled, that's great. You should start, one person should be focusing on that, and a second team should try to focus on very systematically trying to make the diagnosis. Simple things like cardiac tamponade, rupture, cardiac occlusion. So these are if you do both simultaneously, you'll actually get.
I think that's key.
And this, by the way, is one of the reasons why I feel so strongly about having transesophageal echo. Because if you don't have transesophageal echo, and now you're wondering and you're wheeling in a machine and trying to get a transthoracic window, and to make this I mean, you have to make this diagnosis within a matter of seconds or minutes if you're going to have a chance of saving this patient.
Yeah.
So even though this happens rarely, when it happens rarely, rapid diagnosis can be life-saving, which is why I don't think we're ever going to deviate, at least in the foreseeable future, in insisting on doing transesophageal echo for all these procedures.
Just to echo same on Marty's words, I remember last year when they were actually doing a case when Alan, who's really good at it, was talking about doing it under sedation and just transthoracic as backup. This is just a classical example to show you when things go wrong, you won't have time to find an anesthesiologist and you won't have windows to see pictures. So it really is good to be safe. It is good to have full anesthesia, agree? Because if you have something wrong here. And as Marty said, a TE is going to show all those three important diagnoses that you mentioned: rupture, tamponade, and a mitral valve interference or paravalvular leak. So I completely echo the words that people who try to trivialize this procedure and not have anesthesia and TE, I don't think it's right. And this is rare, and life is precious. So even if it's 1 in 100, it's precious.
Right,
Yeah.
and I think
Totally support that. In fact, that was my comment, and I think that it sometimes amazes me as to how Europeans are able to just take it so casually. And it's when the day that things go wrong, that's when you start realizing how easy it is to trivialize a very important procedure just because it becomes routine. And there's nothing like routine in interventional cardiology, and especially when you deal with structural heart disease. Coming back to this patient, I think that this device was low, and I'm sure there's a valvular dysfunction. And the valvular dysfunction can be mitral, but it can actually be aortic prosthesis itself. If it's not open completely, if it's too deep in, and the valves don't open completely, you have immediate hemodynamic disturbance. And I felt that it was 12 millimeters, Marty. I think it was even more than that if you saw the last picture. It actually had a lot of valve flaring out at the bottom. When we put these core valves are like little, they're just 4 or 6 millimeters out. This valve actually flared out in the left ventricle.
I've got a question to the panel. It's from the audience.
Yes.
Yeah. I noted that the pigtail was still in the coronary sinus even after deploying the valve. Is that intentional? My learning is you pull it back at the time of deployment. Do you think that could be causing problem? Because there was some staining of the right coronary sinus.
it's different with the Edwards system than with the core valve. I know with the Edwards system, we always pull the pigtail back before deployment. With the core valve, it's sort of a controlled, and they generally, I know I've seen people deploy it routinely with the pigtail in it, and then and then with a wire getting it out after. With the self-expanding stents, it's a little bit different.
Yeah, you can. I don't think that was causing the issue. That you can always pull it back. You can straighten and pull it back. I'm just very clear that the valve got pulled into the left ventricle because as it was low down, and if it's low down, you must remember that what it's going to do is move into the left ventricle for two reasons. Firstly, there's a traction which you have to give because it has a tendency to move down as it's unsheathed. But the structure of the valve is an hourglass valve. If it's slightly deep in, then it would move down deeper because of the hourglass of the valve itself.
Right, and I think that's an important point. And it's the diagnosis, the MR didn't look terrible on the echo, but the patient was hypotensive, so it's hard to truly assess. But the TE, as Marty said, is invaluable to making that diagnosis and treating. And as Saibal said, I think those are the key aspects. Someone's focusing on supporting the patient, and then someone else is looking at what do you do in terms of treatment. These complications are rare. Coronary occlusion is less than 1%. LV perforations are less than 1%. Iliac injury usually manifests later and wouldn't manifest in this setting is low. But as Marty said, one scenario is you get MR, you get LV dilatation, you get ischemia, you get this spiral that it's hard to recover from. And the patient, we've had scenarios like this where the patient doesn't recover. We end up starting CPR and we give some CPR for a brief period of time. And that circulates enough, and so you get enough pressure head that you can start that process, because once you start the ischemic spiral, you have to break it. And sometimes the only way to break it is to put the patient on pump and support. And we've seen that happen in certain scenarios, especially for the transapical. So it could just be that it took a while to deploy, there was MR, whatever scenario, and you need to support through, or it could be, as Ashok said, the valve is low, and there are other scenarios.